Delegate Cherry, Delegate Cohen, Delegate McQuinn,
Here. Oh, sorry.
Delegate Walker,
Right.
Delegate Cousins, Senator Peake, Senator Pekarsky, Rebecca Bowers-Lanier, Dr. Michelle Boyd, Angela Moore, Tammy Bartlett, Dr. Gregory Hunley,
Here.
Superintendent Coons, Commissioner Shelton, Senator Favola.
Here.
You have a quorum, Madam Chair.
Thank you. Thank you. Colleagues, the first item on our agenda is the election of a chair, and then we'll also move to the election of a vice chair. Is there a nomination for election of chair?
Yes, I nominate Senator Favola.
Okay, is there a second? Okay. Motion has been made and seconded. I guess there's a motion to close nominations. Okay. Is there a vote? All those in favor? Maybe we have a unanimous vote.
Aye.
Aye. Thank you so much. Is anybody wishing to abstain? Hearing none. Thank you, colleagues. I'm honored. It's now time to nominate a vice chair.
Madam Chair, I'd like to enter the name of our highly esteemed delegate from Colonial Heights, and that is Mike Sherry.
Thank you. And there's a second. I move that nominations be closed. Okay, and the name before us is Delegate Cherry for vice chair. All those in favor signify by saying aye. Aye. Delegate Cherry will be our vice chair. Thank you so very much, colleagues. He has given us permission to nominate him so he may continue in this role. So, thank you. Next item, we do have the overview of purpose and duties of the committee, but to give you a flavor of what our scope has been and continues to be, I'm going to ask Ryan Brimmer to give us an overview of legislative proposals that were introduced in this past session that this committee heard as a committee. Some may have passed and some may not have passed.
Thank you, Madam Chair and members of the committee. I think I know most of you, but for those who don't know yet, I'm Ryan Brimmer. Provide support to this committee on behalf of the Division of Legislative Services. So first, just very briefly, an overview of the purpose of this committee. It's a very simple one in the statute, and that is to review and provide advice to the General Assembly and other policymakers regarding proposals that require local school boards to offer certain health services in a school setting. And so with that in mind, as you mentioned, Madam Chair, I just wanted to quickly run through the types of things that the education committees saw this past session in the school health arena. You all had a ton of bills, so I tried to organize it into a few basic categories, and those are student instruction, teacher training, student nutrition, medication administration, student physical examinations, and then just a few miscellaneous on plans, policies, and guidelines relating to school health. And then in terms of broad themes, I think you saw a very heavy focus on mental health and also a strong focus on opioids. So moving right through, first on student instruction, Delegate Sullivan's House Bill 121 passed. That now requires the Board of Education to include in the SOLs for health education for grades 9 and 10, in-person or online severe allergic reaction awareness training, and that includes certain topics enumerated in the bill. Also in the category of student instruction, Delegate Converse Fowler's House Bill 134 passed. That will require DOE in consultation with stakeholders by November 1st of this year to develop and submit to the chairs of the education committees age-appropriate and evidence-based education materials concerning the risks to health and safety that are posed by opioids and guidelines for school boards for incorporating these materials into instruction in the school division. Next, Delegate Clark's House Bill 1473 requires DOE to develop, and in collaboration with the Department of Health, a fentanyl education and awareness informational one-sheet. And then that bill also requires each public high school, that includes grades 9 through 12, to distribute this informational one-sheet to each student in grades 9 through 12 during the first 2 weeks of school.
Mr. Brimmer, I would expect that the information distributed to the students would be age appropriate, so the students would in fact understand the risks of opioid use and
Madam Chair, I would assume the same thing. DOE, I think, is currently working on this, and we have representatives on the committee and in the audience who could speak to that. I don't think the bill specifically mentioned age appropriateness, but usually for things of this nature, when you're sending something home with parents, there's an understanding of that this would be something that high schoolers could readily understand and would be appropriate for them.
Mr. Brimmer, one other question. It would be helpful if this committee actually got a copy and perhaps even a briefing from the Department of Education on what they would consider a best practice on the informational one-pager that I guess school boards will be expected to adopt and ensure that their public high schools disseminate the information. I think it would be helpful to get a briefing on that.
Okay, I have follow-up with Superintendent Coons and others. And, yeah.
Okay, thank you.
Madam Chair?
Yes.
I don't know if we're going to have any conversation, but I think that, and I don't know if that bill for House Bill 1473, and Mr. Brimmer said about 9 through 12, so that means that we will not be sharing that information with middle school students? Is it?
Yes, Madam Chair. The bill was specifically targeted to high school for this informational one sheet.
Delegate McQuinn, is your concern that perhaps it should be
Yes.
distributed
Absolutely.
at an earlier age? Although the law just talks about high school, there's nothing prohibiting the Department of Education from asking school boards to adopt policies for children earlier than high school. And I think that would be something this committee would be interested in asking the Department of Education to do. And if it's with your concurrence, perhaps I will write a letter to the Department of Education suggesting that. Is that
I think
concurrence? Okay, thank you.
Okay.
Yes, go ahead.
Thank you, Madam Chair. I just have a question for this bill. Ryan, sorry, does this include like a date by which this will start to be distributed in schools? Did the statute include a date?
Madam Chair, I don't have that written down in my notes. I think this bill is effective in due course, and so that the understanding would be
Is it
that
normally
DOE...
July 1?
The bill is effective July 1. I think the understanding would be that this would be in process and hopefully going out within the coming school year or the next. I don't know if Superintendent Coons can speak to that. But. Okay, there you go.
Thank you. Okay, go ahead, Mr. Brimmer.
Thank you, Madam Chair. So next, we had Delegate Price's House Bill 603, which passed. This requires health instruction provided to elementary and secondary students to include certain topics related to mental health, including general themes of social and emotional learning, signs and symptoms of common mental health challenges, and mental health wellness and healthy strategies for coping with stress and negative feelings, including conflict resolution skills. Next, Delegate Reeser and Senator Boysko had identical bills that passed that require the Board of Education to develop SOLs and curriculum guidelines for research-based hazing prevention instruction to be provided as part of physical or health education instruction in grades 9 or 10. And then it requires age-appropriate, extensive, and current education about hazing including examples, dangers, and then information on school policies and laws relating to hazing.
Brimmer, develop standards of learning. I think that's usually it's a high bar. So I think that, could you explain to us a little bit more how you would develop a standard of learning regarding hazing policies?
Madam Chair, the standards of learning are reviewed and updated on a set schedule, usually a 7-year schedule. So what this bill says is the next time those are coming out before the board to review those health standards, that they're going to look at hazing and incorporate these elements into the standards.
Into a standard of learning.
Yeah, so then it would be required to be instructed pursuant to those standards.
Okay, so it would be integrated in the curriculum. There would be a certain standard of learning associated with it. There won't be a test on it, but it's very much will be part of the curriculum, which I think is a really good thing. Yes, Superintendent?
Yeah, so in 2027 is the next time health standards will be reviewed. Those standards go through a series of committees. This will be a component of those reviews and incorporated into those standards. And then the standards of learning would be in place for the next year as part of the required components of instruction.
And there'll be public input on those, what the standards of learning should be, and you'll be using, hopefully.
Yeah, there are 2 rounds of public comment. There's a round of public comment to review the current standards and make recommendations. And then once the standards are drafted and revised, there's another round of public hearings as well.
It might be really helpful to inform the committee of when those public hearings are.
Absolutely, we'd be happy to do that.
Be something we might want to know about. Okay.
And finally, Madam Chair, in the category of student instruction, Delegate Siebold's House Bill 1221 passed. This permits each school board to provide a program of instruction on menstrual education as part of any health instruction offered at such grade level in grades 4 through 8 as the school board deems appropriate. Moving on to the category of teacher training, Delegate Henson's House Bill 224 was vetoed by the governor. This would have required each teacher or other relevant personnel employed on a full-time basis to complete mental health awareness training that addresses the needs of youth populations that are at a high risk of experiencing mental health challenges and disorders in accordance with evidence-based best practices. Current law requires teachers to complete mental health awareness training, but doesn't contain what would have been these new requirements relating to the specific topics in the bill. Next, in the category of student nutrition.
Sorry, I just wanted to ask, may we get any, or was there any information on why it was vetoed? I know sometimes vetoes come with some comments.
Madam Chair, there was a veto explanation which I did not review before this meeting. It's out there. I just can't remember. I apologize. But the governor did submit one.
Usually if you check the bill and you go to the status at the bottom, it will say governor's actions. Sometimes the veto message is there. I don't know if it's still there.
It should be right there, yeah.
Yeah. So I don't know if you're familiar with LIS.
I can follow up with you momentarily when I get back to my computer on that, yeah. So, Madam Chair, next in the category of student nutrition, Delegate Bennett Parker's House Bill 686 did not pass. This would have basically provided that each school board require each school in the school division to participate in the federal school lunch and school breakfast programs. And then the bill also set up sort of a framework for reimbursement for that at the state level based on a certain formula established in the bill. Senator Rome's Senate Bill 283 started in that same posture, but was sort of pared back to a bill that did pass, which requires the superintendent of public instruction to convene a stakeholder work group and to report to the new Joint Subcommittee on Elementary and Secondary Education Funding by November 1 of this year on the estimated fiscal impact of offering those free school meals to students statewide. Next, in the category of medication administration, Delegates Sewell and Senator Pillion had identical bills that passed that require each local school board to develop and implement by the start of the 2025 school year plans, policies, and procedures for one, providing at each public public secondary school that includes grades 9 through 12, a program of instruction on opioid overdose prevention and reversal. Two, the procurement, placement, and maintenance in each public elementary and secondary school of a supply of opioid antagonists equal to at least 2 unexpired doses for the purposes of opioid overdose reversal. And three, the possession and administration of an opioid antagonist by any employee of the school board who's authorized by a prescriber and trained in the administration of that medication. Delegate Bennett Parker's House Bill 1039 also passed. If you were on the committee last year, you'd recognize this bill. The committee did review and approve this concept, and it did pass. This basically permits school boards to have policies for the possession and administration of nasal or injectable glucagon for students who are diabetic. Next, in the category of student physical examinations, Delegate Hayes' House Bill 1279 passed. This basically requires the Department of Health and DOE to look at the school health entrance form, look at streamlining it and making it available in electronic and print formats so that it's more user-friendly for parents and health providers. Senator Pekarsky's Senate Bill 395 was continued to the 2025 session. This would have provided that students would not be permitted to participate or try out for school athletic teams unless that student received both the physical examination, which is required now, and also a mental health assessment. Current law only requires the physical examination and not the mental health component. So that bill was continued to 2025 in the category of just miscellaneous other health-related bills. Senate Bill 498, Senator Carol Foy's bill, did pass. It requires the Board of Education to establish guidelines for school-connected overdose response and parental notification policies to aid local school boards in the implementation of such policies, and then requires the guidelines to include certain enumerated items such as ensuring sensitivity to privacy and things of that nature. Delegate LaVere Bowling, her House Bill 936 failed. That would have established enumerated requirements for school boards to ensure indoor air quality, such as identifying a designated individual to oversee the establishment of a preventative maintenance schedule for the HVAC system in each school in the school division. And finally, Madam Chair, Senator Rouse's Senate Bill 181 would have it failed. It would have required each public elementary or secondary school to develop a cardiac emergency response plan that addresses the appropriate use of school personnel to respond to incidents involving an individual who's experiencing sudden cardiac arrest or a similar life-threatening emergency on school grounds or at school athletic events. Madam Chair, that I hope gives you a sense of the magnitude of the workload of the education committees in school health this past session. And also, I just wanted to mention that if there are any bills on this list, especially in the failed or continued category, that the committee would be interested in reviewing further, I'd be happy to get in contact with patrons and see if we could set that up for a future meeting of this committee.
Colleague Senator Pekarsky.
You can call me Stella anytime, Senator. I was just going to comment on my bill that was continued and just a little bit further about what this was. This had two parts to it. What we're seeing now is in order to participate in sports, you must obviously have a physical. But what is happening with the way the requirements go on the dates when you have to have this physical completed, which is after, I believe it's May 1st of the school year, we are seeing a burden on parents and on pediatricians because everybody is flooding pediatric offices during the summer and they are not having enough time to actually see their sick patients. So they have been asking us to adjust this timeline to allow it to be, from the beginning of the year so kids can actually go when they're supposed to go to get their physical and they're not postponing it, which they are also, means they're postponing their vaccines and care and et cetera. The second portion of this was what we are seeing is because of this requirement, some people are not even going to the pediatrician anymore. They're taking their children to CVS, to clinics, to wherever, school grounds. So when you go to your pediatrician, as part of your physical, pediatricians do a very quick mental health, it's like 3 to 5 questions, screener to see is there anything there, are there any red flags? But if these kids are not going to their pediatricians once a year, they're not going to a provider who can catch some early red flags. So I just wanted to make sure that people understood this. I am in the process of writing a letter to VHSL to have them try to work on this from that end, but it is something that we need to fix. So thanks for indulging me.
Yes, no, thank you, Senator Pekarsky. This is a very important topic, and you're really not asking for anything new. You're trying to adjust the timing so our students actually do have the benefit of the public health, of the mental health screening. Yeah, that's very helpful. Before we move on, staff, is it possible for me to have a regular screen here so I know who my members are, and if they're in the queue and they would like to speak? It would very much help me. Right now, my screen is... Okay.
Well, I have mine on to speak.
So colleagues, I will try to look down to see if you have your microphone on or if you wish to speak. And Delegate McQuinn, do you have a comment, please?
Yes, thank you. Thank you, Madam Chair. In terms of some of the issues that we'll have an opportunity to discuss, I certainly like to hear more about the mental health aspect of what we're doing and how we could be more helpful. I am aware, and I don't know if they're doing that in all the school systems, but there are some school systems that have actually mental health day that kids are given opportunity to stay at home or do whatever they do to their parents while they're at home. But however, how does that, how is that integrated into what we're trying to do, or if it is? Because a mental health day, I'm not clear about exactly what that means, except for kids don't attend school on that day. But if there's something of substance that we could do to help support young people and those who are even educators for that matter. But I'd just like to know a little bit more about what's going on in the Commonwealth as it relates to mental health and how we are addressing some of the challenges and needs that young people are having.
Let me see, I don't know.
Thank you, Madam Chair.
Yes. This one relates to Senator Rouse's bill that failed, Senate Bill 181. There was a young student aged 15 in Hopewell this past week who passed away on the field. And one of the concerns that we have with the school divisions is that there are suggestions and guidelines for school divisions, but how they are implemented and any kind of standardization that might happen. Like there was an AED, but perhaps it wasn't out on the field at the time, and that was what happened. There wasn't a requirement, there's only one in the school. It's kind of like, my concern is there a way to standardize? Is there some kind of method that we can get some way to communicate with school divisions around the issue of sudden cardiac arrest and heat illness and standardized ways of dealing with it? And I know that the superintendent probably would have problems with that in as much as if you've seen one school division, you've seen one school division, and not all of them have standardized ways of dealing with things. I'm concerned. So I don't know what we can do with it. I just continue to worry about
That was
it.
Member Bowers Lanier. I don't know what, Superintendent, would you like to respond? I don't want to put you on the spot, but.
I'm happy to elevate guidance in our newsletter and in our communications with schools if that would be helpful.
It might be.
I'd be happy to put communication in our weekly newsletter.
It has with most services that are provided by schools outside of the mandated SOLs and other curriculum requirements, there's variation. And there's some best practices, and maybe there's examples of where schools need to do more. But I think school boards might welcome some guidance, and that would be appreciated. Okay, Delegate Cohen.
I think this is something my colleague, Senator Pekarsky, and I worked on with Fairfax County Public Schools. And so just to your point about best practices, I think that we do have some counties that are definitely leading the way in some of this. Our athletic trainers made a really big push in our county to ensure that anytime that there's a football game, that there's an AED on the field, that every high school has two, so that we are constantly having multiple events. Even that is not enough, to be honest. I think maybe just to Superintendent Coons, and maybe this is a conversation with the VHSL, but where we have meets that are at schools, and right now what happens is that only one athletic trainer is assigned to that. And so I also think maybe that's something, if we want to talk about as a committee, about a recommendation about athletic trainers. Our coaches are all trained on AEDs, our ATs are all trained, but I think the number of athletic trainers, we have just at my kids' high school, 5,400 students and 1.5 athletic trainers. So I know money is always an issue. Certainly we found that in Fairfax County, but I do wonder if we want to change that, take a look at that ratio potentially.
Might be something we should take a look at. It certainly has to do with the health and welfare of our youth. Why don't we put that on our agenda for next time? And perhaps after the presentation, the way we normally work is if a presentation comes forward and there is a recommendation, I ask staff to keep track of recommendations. And then hopefully in a November meeting, we can act on recommendations in the sense that we can offer a recommended approval. So if legislation comes forward in that area, we can say the Health Services Committee endorsed it. So I would just ask staff to keep track of recommendations that come up from our presentations, and then we can act as a body. Okay, so are you Dr.
Hundley? Yes, ma'am.
Gregory Hundley?
Yes, Madam Chair.
Go ahead, please.
As a director of the Heart Center here at VCU and a practicing cardiologist, I'd be happy to offer my services in any way to bring forward guidelines from American Heart Association and things of that nature that could be of any help in the regard on this issue. Because clearly, I mean, time saves lives, and getting these devices in the right situation, it just is a major game changer. So be happy to help in any way to this committee.
Delegate McQuinn?
Yeah, I don't know if drills are done periodically. You know, maybe a drill would be helpful, you know, just so that those, particularly, you know, for the athletic fields, every now and then they do a drill so that everyone is very much aware who's on first, who's on second, who's on third under those kind of circumstances. And if the person that's closer to the door, then what is the defibrillator? If that's not there, then, you know, I think it's just wise for everyone to be aware of what need to be done, and if they're there in a certain space to get it done under those. And the only way you'd know that is basically, for the most part, is doing drills. You know.
And maybe
yes.
And then they are? Oh, okay. Yes, Member Moore? Yes. Go ahead.
So anyway, my comment for that is just for the AEDs that are outside, just to make sure everyone is aware that it has to be in a controlled climate case, so it's very expensive. So that's what's kind of holding a lot of schools back from having the ones out on the field as opposed to in the building, because the epinephrine has to stay at like room temperature. Can't be too cold or too hot. So that's one thought. Like if you were going to mandate to be out on the fields, then there'd have to be some type of funding either from the school or somewhere to put those in, which they'd be well worth it if it would save a life. So that was one thing. And then the other thing, you're talking about drills and such for cardiac arrest issues. We do have something in place. I think when we did the AED in every building, I think in that written it said that there need to be a plan in place or instructions or something. That doesn't mean they're all actually doing it physically, a walkthrough or a run-through, whatever. But I can tell you a lot of the schools in Virginia now, the school nurses are helping them get Code Adam certified, which is helpful to practice the drills. They get the whole team together, you know, what needs to happen in the event of an emergency, whether it be an EpiPen or seizure or whatever, grab the AED. That's been very helpful. So I don't know if you all would want more information to have someone come in and just describe what that Code Adam is, because it's a wonderful program.
Perhaps we can integrate that into the presentation on safety on our sports fields.
Absolutely.
Yeah. So we've got two excellent topics for our next meeting. I think we're going to be a very busy committee. Okay, colleagues, if you don't have further questions on this part of the agenda, we can move on. That's okay. Delegate Elizabeth Bennett Parker, I don't think she's with us right now. Oh, she is in the audience. Excellent. You wanted to make a presentation on potential legislation that you expect to offer in 2025.
Yes, thank you, Madam Chair and members of the committee, for the opportunity to present a bill I'm working on for next session for your consideration and feedback. Earlier this year, I heard from one of my constituents whose daughter has epilepsy. She has a prescription for seizure rescue medication, which is administered nasally, like Narcan in the case of a seizure. To be effective, it must be administered within 5 minutes of the onset of a seizure. However, the school system's policies require that her medication must be kept under lock and key in the nurse's office and that only the nurse can administer the medication. This concerns my constituents because the nurse may not be able to obtain the medication and get to their daughter in time if she were to have a seizure. Further, her teachers have shared that they would be comfortable administering the medication if it were legal. Currently, state law is silent on this issue. The bill draft before you is permissive and would allow a prescriber with parental consent to authorize trained school employees to administer seizure rescue medication if a school nurse is not present, to ensure that students with epilepsy can access timely treatment in school in case of emergency. Ryan Brimmer assisted in drafting with this bill, so I are here to answer any questions you may have at this time. Thank you so much.
Thank you, Delegate Bennett Parker. I have a question. I am reading this to be that this would in fact be a requirement. Is that a correct read of this? This would be a...
Madam Chair, my understanding is that this is permissive, or certainly that was the intent, to the prescriber with parental consent. It would allow for this to happen, but it would not, I guess, mandate it. And I'll defer to Mr. Brimmer to confirm that.
Mr. Brimmer.
Yeah, thank you, Madam Chair and Delegate Bennett Parker. Yes, this would be permissive. So all this bill would essentially do is authorize the prescribers to authorize the use of this medication with the guardrails that Delegate Bennett Parker described, which is parental consent. And also, this would only be in the case where a nurse or a doctor is not present to administer the medication itself. So in terms of the perspective of the school board and school personnel, this is all a permissive structure to this bill.
Just to be clear, it's permissive whether or not that service is provided, and then it would be permissive in terms of whether the prescriber would seek parental consent? Just to be clear.
Madam Chair, yeah, I think that's correct. So this, I guess another way to look at it is that this would never be an option unless a parent came forward and wanted this medication to be possessed and administered by the school personnel, in which case they would go to the prescriber for the medication, and then the medication would be administered, but only if the nurse or doctor is not present to administer it.
And to add to that, Madam Chair, Mr. Brimmer, if I'm recalling correctly, I believe you had mirrored language in this section from existing code, or am I mixing up bills, about adrenal insufficiency?
Yeah, Madam Chair, if you were to turn to page 24 of the bill draft in your packet, this new provision mirrors almost word for word an existing provision in code relating to the administration of medication for students in adrenal crisis. Really, the only difference is the nature of the illness and the type of medication, but otherwise it's the same sort of structure.
And this is a question for the patron. This is not the current practice now.
My understanding, Madam Chair, is that the law is currently silent on this matter, so there is not express permission to do this. Does that make sense?
Yes, okay. Yes. And I guess our professionals would rather want some explicit authority that they can use or...
That is my understanding, and certainly makes folks feel more comfortable.
Okay, I am going to first ask Delegate Cohen and then Member Moore. Okay.
So, and I just have a response to that, just to kind of give you an idea what happens in schools. You know, we have to have a doctor's order that has to be written by the doctor to say it's okay to give my child this medication, and, you know, trained personnel may be able to do that. It's important to know that LPNs are able to provide training, but LPNs are not able to check anybody off on a skills assessment, so that would require a registered nurse in the building for just, this is another medication, what would require that. But typically, you know, we don't hold these kind of medications in schools because they don't have a very long shelf life, and plus different doctors prefer different methods. There's diazepam, you can get it rectally, you can get it intranasally, there's one that's got Versed in it now, there's different things. So I think it would just be important that it's worded just exactly right, and just already know that the schools are already going through that process, or they should be, to have somebody trained as long as they're with that child, either on the bus or in the classroom, community settings, or all three of the above. But it has to start with a seizure plan from a physician or NP or a NP, PA. It would have to come from them, or a DO.
Ms. Bennett Parker, do you have a reaction or comment?
I was trying to take notes from that. So I think, again, the intent of this is to be permissive. I understand. I don't know that the intent of the legislation is at odds with what you were saying. I think it's meant to be to clearly express that permission so that folks can use this. But I certainly appreciate your feedback in terms of making sure that we get the language right, and would be happy to follow up with you offline as well.
I too interpreted the fact I don't think there's anything here that's at odds with what you just said. Would you agree?
I would agree, other than it would just be medication possibly kept at the building, if that school would decide to do that, I guess. And then they would have to have policies and such in place for that as well.
I do think school boards would have to adopt some policy here. Would you agree?
That's what I was going to address there. So there's got to be some authority there, because if you require an RN or certain licensed people to deal with these drugs, in some of our rural areas, that may not be possible at the time.
Right, so sometimes they just hire a contract RN for the time being, just to get that training done. So we do make sure everyone's trained, but it's just more difficult when you have all these medications, albuterol, EpiPen, naloxone, glucagon, now the Versed or diazepam, and the AEDs. That's all going to fall under the realm of a school nurse. And we have right now, there's nothing saying what a school nurse is defined by, and or that every school needs to have a school nurse in it. So that's where, on my perspective, the trouble lies with that. It's kind of a liability.
Delegate, you may want to consider adding language about the school board adopting a policy that would permit the actions that you are outlining as permissive.
Thank you.
I think that might be helpful. And then they can also tailor the policy to their own specific situation, if it's a contract nurse or whatever. So maybe you want to consider adding that language. If you choose to continue to meet with stakeholders and give us a revised draft bill at our next meeting, we will decide whether or not we're going to endorse this. But to me, it's something that I think could be helpful. So please put this down on our agenda for action at our next meeting, expecting we'll get a revised document.
Great. Thank you, Madam Chair, members of the committee.
Oh, I'm sorry. Senator Pekarsky.
Thank you. So I'm very empathetic to this because my daughter has epilepsy and has seizures in school. So she has a seizure plan run by public health nurse. The public health aides are up to speed on what that is. And, while I have not left rescue medicine, my understanding is that they can right now have that rescue medicine in the, aides room, and it can be administered by them. My worry, or things to think about when we start talking about other folks administering this, is number one, just how many things they have to do. I think as a former teacher, it can be very scary. Not everybody, seizures are scary, period. If you're not trained in living through those and being able to respond to those, I don't know that everybody can be comfortable with doing that. Then you have, what are the requirements if they go on a field trip or if they're off campus? I believe that with EPI, they have to take that with them. So now will this be something else that they'll have to take with them as well? So like I said, I'm very empathetic because it's personal, but I think as we start to add all of these, there's a point where it could even be dangerous. You have somebody who's not a medical practitioner who is going through all sorts of medications. And I just think that's something we really need to think about as this comes back. And you are, talking with folks about it. And I really would, encourage you to talk to some school folks and kind of get their perspective on that as well. Thank you.
Thank you, Senator Pekarsky. As with all good things, we always have to get multiple perspectives, as many perspectives as we can, because when we pass laws, we want to make sure they can be implemented. the way they were intended, and we don't want to do any harm. Hopefully, we can do some good.
Can I just?
Yes,
So currently in the buildings, epinephrine is required in the building. It doesn't even leave with the student field trips, anything like that. It stays in the building. So that was the first thing. But everyone has to be trained, whether it's somebody who has a new diagnosis of seizures, whatever it is, the registered nurse has to train everybody who might be around that student to make sure they understand what they're looking for, where the medications are kept, all that kind of stuff. That's already in place. So it seems like this would be the only difference is we might be able to keep it in stock in the school or something, which wouldn't necessarily be a bad thing. All these other ones are medication that are for emergency purposes only. And if you're giving any of these, you're going to call EMS because we're not able to monitor after medication like this would be given. So I don't think it's a bad idea. I just think that it needs to be also known that when a nurse provides training to somebody, you can't train somebody who's unwilling to be trained, to understand what they would have to do, or to take on that responsibility after their training. You can't send somebody off for that.
I guess this is a question for Mr. Brimmer. And really doesn't have any medical background at all. And if something were to happen, expecting that there would be a school board policy that has been adopted. Perhaps you can enlighten us on that.
Yeah, Madam Chair, what we did in this bill draft, if you look at page 9 on line 205, this is basically the Good Samaritan statute to limit civil liability in the case of good faith actions. So we wrote into that statute that if school personnel does administer one of these medications in good faith for a student who's experiencing a seizure, that they would not be held liable in that.
So that's a reference? Is that 54.12?
Madam Chair, this is section 8.01-225 of the Code of Virginia, and the new language limiting liability relative to this medication is on page 9 of the bill draft, on lines 205 onto page 10, line 214.
Okay. That might address some of the issues. Yes, Delegate Cohen.
I wonder if there is, in looking at this, again, I can only speak from the Fairfax perspective, but we do require epinephrine if a child has any history of anaphylaxis. We do require that go accompany a child on a field trip. If it's
their own, if it's their personal EpiPen, we would send it, but not when we have stock in the building, like the safety.
Right.
Right there, it doesn't go out. And it might be a division that you guys do that, and in Chesterfield, we don't do that, but the law doesn't say it has to leave the building, it's just in the building.
So I guess that's, if that's the question to me is, are we making sure that accompanies? I mean, currently, we have a teacher who's designated on the trip that brings it with them. And at least in Fairfax, every year you do your epinephrine training during staff time, in the beginning of the year. So maybe that's something, and maybe Ryan, we can work with you to figure out, is that permissive language that's there and just some counties are doing it, or is that something that we need to look into, because we certainly wouldn't want something like that to happen on a field trip. And I do know there was an issue that we ran into as well about any students who had epinephrine that was assigned to them. If they had anaphylaxis somewhere else, there was some wonky provision in code at some point, and I'm hoping that has been fixed now, that they couldn't use the school's store of epinephrine. It had to be their own. Of course, in practice, that is thankfully not what our nurses did. But maybe we want to check that out too and just make sure we didn't do something funky that is making that happen.
I would say the thing about that for the there are so many field trips that are going out and about with so many different teachers and such. I don't know how it would be possible to have an EpiPen going with each teacher And then once they get on a big field trip, they go into groups, so you might not be close to it anyways for the cost. And we have 70-some schools in Chesterfield. Last year and the year before, we gave between 20 and 30 EpiPens of the stock EpiPens that were there. So out of, I'm thinking 73 schools, each one has 3 doses. So that's, 3 that we have there, but I just don't know how that would work. So you might need to talk to teachers and administrators about that as well, because that would be a huge cost.
So I guess the question, although this is all permissive, if school boards were to adopt policies, the issues would come up regarding travel, and they would come up with maybe students in activities off the main campus. So let's think about that, because we would have to provide guidance to schools, even if the statute read school boards may consider the following. So if they adopt policies, they can decide how they're going to treat these different situations. Just a suggestion.
Thank you, Madam Chair. And to the previous point, I certainly understand the comments made by Senator Pekarsky and Member Moore about sort of training individuals who don't want to be trained, or all of the requirements that we're putting on teachers, which is why I think this was meant to be permissive, and also you have to be trained in order to administer the medication. So I think, but I certainly think your point about sort of the school board policy, and there's other probably language we could work on to clarify that.
What they could consider in their policy.
Yes, thank you.
I do appreciate the conversation from those of you who have boots on the ground. You've been very helpful on this. Okay, colleagues, are we finished with this conversation? We can move on to the next topic. Okay. Thank you,
Madam
Delegate
Chair,
Bennett Parker. Medicaid services for school nurses. So this would have the topic is probably not worded as elegantly as we wanted it to be worded, but we're really talking, I think, about school nurses being able to draw down Medicaid dollars for certain services. And we do have a presenter from DMAS, and I have M. Cooper. Are you Miss Cooper? Welcome.
Thanks.
Okay.
All right.
And Joe Wharf is also here, the Department of Behavioral Health. Okay, go ahead.
Thank you. Good afternoon, Chair Favola and members of the School Health Services Committee. I'm M. Cooper, the Deputy Superintendent at the Virginia Department of Education, and more importantly, a proud mom of a 4-year-old who is starting pre-K next Monday in Chesterfield, who is also a future teacher. I have the privilege of leading our Division of Teaching and Learning, and I'm eager to share the great work of our video team with you all today regarding the Medicaid in Schools program. So this afternoon, you will hear an overview of what Medicaid looks like in schools across the Commonwealth, the latest data we have in terms of staffing and the impact that's being made across our divisions, details from the Department of Medical Assistant Services on costs, reimbursements, and processes, and then finally, some challenges that we're hearing and also opportunities for improvement over the next school year. So in my division sits the VDOE Office of Behavioral Health and Wellness, and that office has 4 school health staff members that support the needs of divisions across the Commonwealth, and that team is led by Joe Wharf, who you will be hearing from shortly. Before we get into the data around nursing and Medicaid in schools, I want to give you all an overview of where this work is in Virginia, some terms that you'll hear throughout the presentation, and then some of the supports that the VDOE staff have provided our nurses and other health staff across the state. So to get started, Medicaid helps cover the costs for qualified people with limited income and resources. Every state has their own Medicaid state plan, and that sets the parameters on how states administer that program. When you think about Medicaid, you don't typically associate it with schools. However, the Medicaid in Schools program began in the late 1980s, and Virginia has been participating since 1991. Through Medicaid, certain health services that are administered in a school setting could be reimbursed. From the beginning of the program until 2014, that reimbursement was only allowable for students with disabilities who had those services identified in an individualized education program or an IEP. That IEP is a program that reviews the achievement goals for that student, academic and health services, accommodations and interventions that are in place during that school year. So this could be for a student who needs medication or support managing a health condition at the school. That student would then go see the nurse and receive those services, and then in an ideal situation, the nurse would enter that information into the division's data system, and it would move through the process of getting approved for reimbursement. 10 years ago, the Centers for Medicaid and Medicaid Services reversed this policy to allow reimbursement services for all students who are Medicaid eligible and receiving services that were reimbursable, so not just students with disabilities that had an IEP. So since 2014, only students with disabilities would be eligible, but now, since 2022, any Medicaid eligible student can have those services reimbursed. For example, if you have a kindergarten student who is on Medicaid, they're at recess on the playground and they scrape their knee, they can go and visit the nurse, and then the nurse can then submit that service for reimbursement. Or you have a student in class who has a headache, they have an upset stomach, they can go see that nurse, and then that visit can be submitted for reimbursement. So nurses have always taken care of kids in schools with hurt knees and upset stomachs, but now they can be reimbursed for those services. The expansion of services to all students on Medicaid is new to Virginia. VDOE worked with our partners at the Department of Medical Assistance Services to revise the state plan for Medicaid reimbursement. It was a 6 to 7 year process, and the state plan amendment was improved for divisions to seek reimbursement for Medicaid services to all eligible students on July 1st of 2022. And that amendment also included other areas, so it expanded services such as mental health services delivered through our licensed school mental health providers and crisis care and screening. Some examples of services that nurses can administer that are covered by Medicaid are breathing treatments for students who have asthma, glucose monitoring for students with diabetes, tube feeding for students with significant cognitive disabilities, and health screenings such as vision and hearing. With the expansion to cover all students on Medicaid, services that nurses have always conducted can now be reimbursed through Medicaid. The VDO team has supported divisions and school health personnel with these incredible shifts in Medicaid reimbursements. Last year, our team conducted over 30 training sessions on Medicaid in schools for about 2,500 people. And as we have more divisions wanting to implement the Medicaid in Schools program, the VDO team will continue to provide those trainings and ensure that divisions know how to navigate this process clearly so it will be successful. I'm now going to turn it over to our Director of Behavioral Health and Wellness, Joe Worf.
Thank you, Deputy Superintendent Cooper. Good afternoon, Madam Chair, members of the committee. Again, Joe Worf, proud husband and father of 3 boys residing in Midlothian, Virginia. School health data in Virginia has been collected for over 20 years, mostly on a volunteer basis for school divisions with a response rate of about 60 to 65%. Included in a report to the governor in 2021 on school nursing services in Virginia, one of the recommendations was that there be a mandate for school divisions to submit health data, which included areas of health conditions and staffing in Virginia. That recommendation was approved, and the 2022-2023 school year was the first year that school health data was mandated for Virginia schools. VDOE was able to get a 100% response rate, and I'd like to share some of that data with you now to better inform the question of whether the Medicaid in School program could potentially support nursing services. This is our Virginia-specific data on school health staffing. As mentioned before, the 22-23 school year was the first year that the school health data was mandated in Virginia. We found that the data looks promising overall, but there are areas of improvement where staffing is low. All schools reported for 22-23, that number being 1,932 schools. For schools in Virginia, 68% have a full-time RN or registered nurse on staff. An additional 14% have a full-time LPN or licensed professional nurse on staff. You will see in the third bullet the acronym UAP. These are unlicensed assistive personnel, and many of the 14% of the UAP staffed in Virginia are from the Fairfax and Loudoun region, as denoted on the slide. UAPs are trained in certain aspects of nursing services and can perform services that are Medicaid billable. They are not licensed and must be supervised by a registered nurse. 47 schools have a part-time registered nurse on staff, and 19 schools are unstaffed. When we look at the data overall, we see that 18% of our schools in Virginia are unstaffed, understaffed, or have unlicensed personnel. The image on this slide gives you a visual of the school divisions in Virginia that are unstaffed, understaffed, or employ unlicensed personnel. Please note that the white or light gray shaded areas are those divisions that are actually fully staffed.
Question.
Yes, ma'am.
I'm sorry, Mr. Worf. On slide 10, when you say total schools reported, you're looking at the specific school building or school systems? I guess on slide 10, are we talking about school systems, or?
Madam Chair, schools, actual schools.
Actual schools,
yes.
Okay.
So as I was mentioning before, note that the white or light gray shaded areas are those divisions that are actually fully staffed. It's the shaded darker blue-green colored divisions that represent those divisions that are unstaffed, understaffed, or include unlicensed personnel. We can see large areas of Northern Virginia that are shaded blue-green, and these mostly represent the UAPs hired in those areas for Fairfax and Loudoun counties. School divisions across the Commonwealth have different staffing formulas for nursing and health services, with some employing UAPs and others contracting the UAPs from local health departments. We also see high areas of shaded divisions in the Shenandoah Valley that represent more of our rural areas. Far southwest Virginia and the Tidewater region also represent higher shaded areas. The data on this slide displays the school health visits or encounters for students for the 22-23 school year. It represents the number of times a student has entered a clinic or office for a nursing service. RNs had the most student encounters with nearly 5 million. LPNs and UAPs each had over 1 million visits. As a reminder, we have 1.24 million K-12 students across the Commonwealth, so the 7 million clinic visits equates to about 6 clinic visits per student, or 42,000 visits per day. What we see with this data as we explore the question of whether the school-based Medicaid program can support nursing services is that the volume of school nursing office encounters is very high.
Excuse me, I
Yes.
have a question
Sure.
from a member. Delegate Cohen.
I just wanted to ask, I see here it says 198 UAP staffed in Fairfax County. But those are, in addition, those are our clinic aides. We have 200 schools. Those are our clinic aides who are unlicensed. But we do have RNs that are either split among a couple of schools. Our goal as a system, and it was funded through our county, was for a nurse in every single school. So I guess my question when just trying to look at how we dive into the data is that in Fairfax, we're in a shade that says we're understaffed, and yet those UAPs are actually additional staff on top of RNs or LPNs. So I guess my confusion with how the data is reported is if you only looked at the number of UAPs and not recognizing that they were additional staff, those counties would look understaffed, but in reality, that's not quite showing the picture, I guess, is my
Yeah,
question.
thank you for that. Yes, and we know that in Fairfax area, RNs and UAPs need to be supervised by an RN, and so they are RNs that are also there, but there are a large number of UAPs which are unlicensed professionals, and that's why they're in this. We will pull that data out in a couple slides, so just the unstaffed and understaffed. What we see with this data as we explore the question of whether the school-based Medicaid program could support nursing services is that the volume of school nursing office encounters is very high and provides that opportunity, now with expanded services outside the IEP, for school divisions to seek reimbursement for those students on Medicaid.
Yes, I just have a question.
Delegate Cousins?
Thank you. I just have a question
Yes.
about the funding structure. So how were these encounters funded sort of before this change in 2022, before the Medicaid reimbursements were?
The office encounters, so all students would get services from school nurses. Before, students with IEPs, our special education students who were Medicaid eligible, could have those reimbursed. Other than that, otherwise, they would be free of charge to students through personnel hired by the school division.
Okay, I guess what I'm asking is then who paid for, like who, so I understand the services were free of charge to the students, but who covered that? Was it like, is that in the budget? Schools, localities, schools? Okay.
Yes.
Okay.
Sometimes it was localities. Oh, well, can't get this on. In the Nova schools, in the Nova school systems, they get money from their local county public health departments to pay for nurses in the schools. But there may be different models. I'm only talking about one region of the Commonwealth. Perhaps the superintendent knows of different models.
I think the nursing services are funded and determined by local school division budgets. So those visits up there are not necessarily tagged to Medicaid per se. They're just the total visits that school nurses do during the school year that have to be budgeted for local school divisions.
Thank you. I've listed here a regional breakdown with some divisions that have higher percentages of unstaffed and understaffed schools. We have taken the UAP data out here. The divisions listed represent some of our more rural divisions. For the schools and divisions in Virginia that have a higher concentration of understaffed and unstaffed, there may be a higher risk of students not receiving the quality of care afforded to our divisions that hire full-time licensed staff, as well as a missed opportunity to seek reimbursement for Medicaid services provided to those students. Low or no staffing may also have a negative impact on overall student attendance. I would like to reiterate that this data is 22-23, and there may have been shifts in staffing for 23-24. We are still compiling and analyzing that data. We'll now break down the Medicaid in Schools program participation first for all Medicaid services represented, and then we will present a slide on just school nursing services and participation in Medicaid. That'll be the next slide. In Virginia, there are 131 school divisions. We have 108 school divisions, or 82%, that are currently participating in the Medicaid in Schools program. School divisions may seek reimbursement for some direct services and not others, and that is left up to the school divisions. Statewide, $56 million was reimbursed to school divisions in 22-23. Administrative claiming accounted for over $6 million. Our state agency partner will break down the different areas of admin claiming in her slides.
Just quick question. Yes. My apologies.
Yes. No, sure. Thank you.
At least I've received complaints from some school personnel that it's complicated to draw down Medicaid dollars and we need assistance. And it was my understanding a few years ago in the budget, we did allocate money for some technical assistance to schools and how to draw down Medicaid dollars. Is that going on? Are we assisting schools in drawing down Medicaid dollars, or are we at least training them?
Yes, Madam Chair, we're doing a lot of training. Amy Edwards, who is our Medicaid and Schools specialist, I am not aware of that specific monies that was drawn down or allotted for technical assistance, but I know that Amy Edwards, our Medicaid and Schools specialist, is doing a lot of training. Yes, ma'am.
Being provided. Okay,
yes.
So that may be where the...
Yes. Thank you. So those direct services in schools, many of which we showed on a previous slide, accounted for nearly $50 million for a total of over $56 million reimbursed to school divisions from Medicaid. The graph to the right and the third bullet represent the total amount claimed from divisions through what is called the Federal Financial Participation, or FFP, and that our state partners, I should say, at DMAS do retain a portion of the direct services and administrative claiming reimbursement. It is important to note that the reimbursement funds received by school divisions from Medicaid can be used in any way the school division chooses and don't have to be specifically dedicated to a specific position or area of need. The funds received are not also a 100% reimbursement, which may or may not rise to the level of being able to support a nurse in every school. So although it's very difficult to determine the exact amount, we know that with over 20 divisions not participating in the Medicaid in Schools program, there is an opportunity lost to be reimbursed for services that are already occurring in the school. This slide represents school division participation in Medicaid reimbursement specifically related to school nursing services in 22-23. Out of 131 school divisions, 56 divisions, or 43%, participated in direct services nursing reimbursement. We see a lot of room for growth here, and with a number of office visits shown in our earlier slide, we see an opportunity here to increase division participation in Medicaid reimbursement for services. Although we will cover challenges and barriers to utilization at the end of the presentation, I wanted to note just a few here for reasons that we may be seeing such a low number at this time for nursing services. First, this is new work. School divisions are still learning how to navigate a fairly complex reimbursement system that they're not used to. Another reason is that prior to expanded services, when only nursing services were reimbursable through an IEP, nursing services were a small percentage of all services. Parental consent has also been a barrier, as consent now has to be obtained from parents of students on Medicaid that do not have an IEP, and they are often harder to reach, and some are unwilling to provide consent. Having a dedicated staff person responsible at the school level, the administrative burden of this work, not having an electronic system for proper documentation, and reimbursement not being 100% of the claims are all challenges. Lynn Hamner from DMAS will cover aspects of this in her presentation, and I will turn it over to her now.
Good afternoon, Madam Chair and members. I'm Lynn Hamner. I'm from Medicaid, and I work with the School Services Program. Okay, why am I not advancing here? Oh. These are these your slides? Mm-hmm. Sorry. It's okay. Should start with continuum of care. There should be a DMAS slide prior to that. Right there. Thank you. Sorry about that. So I just wanted to say that school-based services provide a continuum of care between the community providers and the schools. Keeping students as healthy as possible facilitates their success in learning. I'm going to talk a little bit about how the reimbursement works. I'm just going to give a very high-level overview. So you're probably used to seeing a physician, and it's a fee-for-service situation where you go and you see your physician and they bill your insurance company and then the claims are paid. However, through the schools, we do what's called a cost-based methodology. And some of those costs are direct health services, specialized transportation, and administrative activities claiming, which I will explain. So direct health services are the services that we offer. And we use a critical component called the random moment time study. And this helps to determine the percentage of staff time that's spent providing the direct services. I'm going to explain the random moment time study in a little more detail. With direct healthcare services, the things that are covered, they talk about planning, how will your students' health needs be met, gathering supplies, reviewing notes, writing a plan of care, and then implementing the plan of care. That's actually the direct service. And then the documentation is also a part of that. What did the provider do for the student? What's their response? Are there any changes in the needs moving forward? There's also Medicaid administrative activities, things like arranging transportation, having outreach, referring and linking, monitoring for services. If, for example, they saw a nurse detected a mental health need, they needed to refer them to a mental health provider, something like that. These components of direct healthcare services and Medicaid administrative activities are a part of the random moment time study. So when you do the time study, what does that look like? It's an electronic program, and the providers go in and they answer questions. And it can go in several different pathways. So you ask yourself, what activity was I doing at the time that I got the email? They'll send you an email and they'll say, what were you doing at this particular time for the student? Was it health related? That goes on one pathway. Or was it educational related? That goes on another pathway, because we don't pay for the educational related activities. Was it pursuant to an IEP? Who were you working with, and what were you doing? What was the activity? And depending on how the moment's answered, the pathway could lead to an activity that is not reimbursable. For example, a nurse may have been assigned bus duty or lunch duty that day. That would not be reimbursable, just like a nursing service. Specialized transportation, the cost of scheduling and arranging transportation is an administrative activity, but the actual provision of the transportation is considered direct health care service. And what are administrative activities claiming? Things like a lot of the schools or school divisions have Medicaid coordinators, and they have a lot of duties. And some of the things they have to do are Medicaid outreach, or maybe you have a family that needs help with applying for Medicaid or renewing your Medicaid, and they will help with that. Those are administrative activities. Things like arranging transportation, training, activities in relation to state or federal public health guidance. I'm sorry, I talk kind of fast. So they put together a cost report, and there's certain expenditures. The cost report calculates the total amount of partial reimbursement each school division should receive for a fiscal year. That's due every year on November the 30th. It includes information about eligible expenditures the school division made during the year. And this is what the cycle of the reimbursement looks like. So you provide the medical service. The nurse, or whichever, the therapist, mental health practitioner, anybody will provide service documentation. They'll file an interim claim that comes into Medicaid saying this is what we did for the student. Then they will get paid on those interim claims. Those claims are matched against the cost report, and at cost settlement time, the reimbursement amount is decided. And I'm going to turn it back over to Joe. Thank you.
So over the past year, we've heard lots of success stories from our divisions, and then also some challenges in implementing this program effectively. There are 4 trends we've heard in terms of challenges. The first one, as you heard earlier from my colleague Joe, is that it's a new process. So our school health professionals and division leaders are learning how to navigate this work. And because this is new, we still have more outreach to do to divisions about the benefits of the program for students so that they can commit to being part of the program. The second thing is that many school divisions aren't equipped with adequate documentation systems, and the administrative burden is extremely high. Depending on the school system and the protocol that's used, there can be burdensome paperwork, duplicative processes, and inefficient systems. So this could look like anything from having to document something on paper first, and then that healthcare professional transferring it into an electronic system. It could also be that a nurse has to chart a student's services in multiple places. And so the system really needs to be simplified in order to provide services for more students. Third, there must be administrative staff to support billing and paperwork at both the division and the school level, like you've heard before. Many of our smaller school systems have leaders who wear multiple hats. So they may be director of transportation and food and nutrition and health services. And so that can really be time-consuming and often delay the submission and approval processes for reimbursements. Without the proper administration staff in place to support the program, it's really difficult to do this successfully. And then the fourth challenge is that the reimbursement structure may not support the funding for nurses. Divisions don't receive a full reimbursement for these services, and the funding can be used for many things. So it doesn't necessarily go directly to funding the nurses doing the work. There's also opportunities to improve the success of this program across the Commonwealth for this upcoming year. So we are eager to continue the collaboration across state agencies, which will really increase the supports and technical assistance that our divisions need to do this well. We've had over 50 divisions this year take advantage of the direct reimbursement, and so we want to learn from those divisions, the ones that early adopted this, to see what went well, what do they need help with, and what can we take in terms of best practices to highlight those for other schools. And then as you saw in the data, there are millions of nurse visits every year, and this really showcases the potential for reimbursement services for divisions, which means they could be receiving funds to support student needs. We are moving in the right direction as we expand the Medicaid in Schools program. Virginia now has a state plan amendment that allows reimbursement for all students on Medicaid and can enable thousands of additional students to gain access to these crucial health services that ensure that Virginia has access to all available funds that support them. The training will continue. As participation increases, the quality services for students will increase, as well as the direct service billing for Medicaid-eligible students, with the result being an increase in funds received that can be utilized to fund school nursing services. Thank you all for your time today.
Yes, Delegate Cohen.
Thank you so much, and certainly you have several former school board members on here who would always be happy to hear ways to free up funds for other things. I guess, in looking at this as you presented, a lot of the challenges are really difficult to overcome. I know for us in our county, our nurses are county employees. That's so right. Unless it's a self-identification or parent identification, it's a FERPA violation if they were able to be told that a child was on Medicaid from school staff. So I know that has to be a big challenge. We have enough challenge just trying to get folks who want to utilize, FRM. And so I absolutely see that as a barrier. One of the biggest things, and I know we're going to get to it here in just a minute, is we were really very fortunate in Fairfax to have, after many years, our Board of Supervisors get behind a nurse in every school. It has been so incredibly disappointing to see that the number of vacancies that we have, we just cannot fill those positions. So after 8 years of begging the board, we finally get it, and it feels like this big celebration. And then on the ground, kids are not seeing that. Schools are not seeing it. We're still having to share nurses among 2-3 schools. So I guess ideas maybe I put back to you all when we talk about kind of the intersection of workforce shortages, workforce development, and student health. What kind of recommendations and what are you all and this administration really doing to try to work on that nursing shortage so that, I guess, in a perfect world, we have to have nurses to be able to even implement this. So what can we do to be helpful in that arena?
Sure, no, that's a great question. That's actually one of the things that we heard from schools, which is there a career pathway for those UAPs, so those unlicensed assistive personnel? What can we do to put them on a pathway to become an RN or an LPN? And so we are working with the Secretary of Education's office to start collaborating on what that could look like with the Secretary of Labor and Secretary of Health. So it's an excellent question. The workforce is super important here, so we're hoping that's one option.
Are there any other questions of our speaker? I guess I just have one question. And maybe this is for staff too. I think it's August now. Maybe within the next few months we can have an update on how schools are addressing these challenges, or what recommendations would be helpful for the committee to adopt, or legislation or budget items that would help schools address some of these challenges. Because at the end of the day, we do benefit by using some federal money, which is available in Medicaid. Mm-hmm. So otherwise, the children are going without the service, or our local governments are paying for the entire service. So the best way forward, both in terms of serving our children and drawing down money, is to get more Medicaid reimbursement. And please advise this committee on what recommendations we could adopt. I mean, if it's a budget recommendation, if it's going back to what I remembered as a technical assistance earmark a few years ago, which maybe my memory's not that great. We'll have to go back and revisit that. But I would be interested in having a presentation in October on recommendations that this committee could endorse and maybe move forward with. Is that agreement? Is there concurrence with that? Delegate McQueen?
Yes. Can I raise a question?
Yes,
please?
yes.
Thank you. Yes, Madam Chair. I think more information will be certainly good for me. I don't know about the rest of it. This has seemed to be very complex in terms of trying to get, I mean, I see where you're going with it. It's just, I'm one of those former school board members, and I know that the localities had always taken care of, compensating nurses. And so now, do the localities stop in terms of them, compensating the nurses, and then we're looking for the federal government to do it? Is this where we're trying to go? And then there was something that really just kind of perked me up a little bit when I got to that last page on 14, and it says the reimbursement structure may not support funding nursing positions, and I'm going, okay, well, then again, it's some more, I just need to be informed more and to understand better where, what is I know what the objective is, but, if all of the schools are able to do this, then what does it look like? What does it look like? What is provided for, in terms of healthcare services for young people? To what degree, I thought, if it was specialized services, I think I would feel totally different, but I'm not seeing that these are specialized services. It is the services that usually are provided, through the educational system, and localities taking care of it. So anyway, I just rambling, I guess.
Maybe.
I'm just rambling because
No, we agree. We're going to try to incorporate some of your thoughts when we get recommendations.
Those are all great points. I'll say one of the great things that we have now is we now have data to be able to pull. And so the data that you saw today is some of that data that we just started collecting. And I think the data moving forward will help inform that. And then the other thing that I'll add is over the next several months, one of our priorities on our school health team is to collect feedback from some of, the suggestions that they have in terms of things that could make things more efficient. How can we reduce some of these burdensome tasks for them? What would make it easier for those school-based health professionals? And then I also think too, across state agencies, we are getting more coordinated and efficient as well. And so I think once we have more information from our divisions, we can include that in a future presentation and then the data as well.
I think we would like you to come back in October with perhaps some recommendations that can help the schools overcome these challenges.
We'd be happy to.
Delegate Walker.
Well, I'll agree with the comments that have already been shared, and we're not going to beat this horse anymore today. I think you understand what the needs are, what we're looking for. Medicaid is not always the answer, and I think the important thing is to remember it's the localities we've got to work very closely with. One question that I have, having been and working with workforce training, is there's such a shortage already of nurses in all localities, especially in ours, everything west of Lynchburg, Southwest Virginia, that are we going to be able to meet these challenges that these localities have? And so certainly there's a lot more questions to ask before we go too far, and I'm concurring with the other comments that have been shared here today. Information is important before we make any final decisions or maybe consider legislation, in my view. So we look forward to the next meeting, and hopefully we're not going to work you to death, but before decisions are made, we've got to have a comfort level. Thank you.
Great.
Nicely said. That's right. We're going to keep digging into this. Thank you, Delegate Walker.
Thank you, Madam Chair.
Anything else on this topic, colleagues? Otherwise, we can move on to our next topic. Thank you so much, Ms. Cooper. Presentation on our local perspective on funding one school nurse per school building, which is where this committee eventually wants to get to, understanding that this does have a fiscal implication, but we're going to get there. Be hopeful. Be hopeful. And you must be Catherine Haynes.
I am.
Welcome.
Good afternoon. Catherine Haynes. I was a school board member. I ended my term last December. I ended as a vice chair at Chesterfield County Public Schools. This is a passion of mine. I am not a nurse. I do have a passion for health professions because I practice as a midwife, and I'm married to Dr. Hunley. My husband, Matt Haynes, I believe works with you. So I have a husband in the health profession for over 10 years. And I'm also a mom of 4. So I come from this from many different angles. And I quit my job to be an effective school board member. Not everybody has that ability, but it means that I answered thousands of emails, had many town halls, and so I think I can offer a fresh perspective and also some hope. I sensed how are we going to get there feeling in the atmosphere, and the reality is that we currently have 14,000 people that are billing using the complicated but doable RMTS in Virginia. And Virginia is a late adopter. I think someone had said 2022. The plan actually wasn't improved until last year, 2023. It was the end of 2023. And I know this because I actually had my superintendent come together with several other divisions, including Loudoun, and I'm not going to remember offhand, but several of the larger purple divisions asking that this money be swiftly allocated to schools who are in need of this critical funding. Georgia and Louisiana were early adopters of this. Virginia was sort of late to the game, I said. And Georgia used this to put a nurse in every school or to move towards that path and drew down about $40 million. So I think if Louisiana and Georgia can do it, Virginia can do it. So our journey, the next slide, we all want a, oh wait, I'm supposed to advance, sorry. I was very spoiled being on the school board for 4 years. Low comms resource agency, so I have the least thrills on my slides. We all want a nurse in every school, but the pandemic put an urgency and a timeline behind putting a nurse in every school. And I was very deliberate about returning schools to instruction, and so crafted a roadmap, and that's how I know Angie Moore, to get there. And people understood, even my parents who wanted the kids back the next day, that we needed to check some boxes. And so one of the boxes that I needed checked was a nurse in every school. And so we had initially in Hanover, people would call me from Hanover and say, we can do it, why can't you do it? And I would say, you have a nurse in every school, and we don't. And people were shocked and understood. Parents needed that assurance that there was a registered nurse. Our ratio was 0.5. Elementary is where we had the problem. Middle and high school, we had 1 in every school, although in our larger schools it was not adequate. And so what we did is once the CARES funding came out, we were able to shift some middle school, high school nurses to our elementary, and then we needed $500,000 for kind of the initial get elementary students back to school. And eventually the full gap for the full return, elementary, middle, and high, we needed 15 nurses, and the cost in 2021 was $1.4 million. The barriers, I heard some information about Fairfax, and I love that we have some school board members, both from Chesterfield, the Delegate McQuinn and Delegate Cohen and Senator Pekarsky. Definitely lean on your school board members. Fairfax actually was a barrier to getting kids back to school because I was lobbying at the General Assembly and hoping that everyone would get on board to fund a nurse in every school. But you had school districts, not just Fairfax, that didn't have, they didn't use the strategy of a nurse in every school. And it makes a difference because there's a difference between a public health nurse and a school nurse. And I'll let the association sort out how that gets put in the code. But a public health nurse is thinking about public health, and the nurse and the RN in the school is building trust. It's a relationship, right? And so how that looked like during the pandemic, from a public health perspective, we need everybody vaccinated. From a building the trust perspective, there is vaccine hesitancy in certain communities. There are religious beliefs. And so just saying, show up for your vaccine appointment, public health perspective, that doesn't work as well. When you build that trust and it's a nurse in a school, you figure out how to communicate to that family and meet them where they are and help them understand how it is a healthier choice and explain about required vaccines and all of the piece. But the point is, it's a child and family, it's a relationship, it's a trust building. It looks different than a public health. Ultimately, it's a public health report, but you approach it differently, if that makes sense. So I'm rooting for a nurse in every school that has a liaison with the public health department so that they're in communication and they're informing the public health department how they can tailor their strategies to reach more people with the important information, depending on the public health crisis at the time. Hiring and retaining. We heard about the shortage. We do have financial flexibility in Chesterfield that some counties maybe don't have. And so we actually had third party do complete salary studies, and we raised the salaries of all of our staff. It was very, very thorough. Again, a third party did it, and that included nurses. And the added duties make it harder to retain nurses. For example, this year, nurses had to come back August 1st, and they had to begin entering the data from all the kids vaccinated over the summer. Please, everybody, if you have not read the JLARC report, please look at that, because when I talk about please do not give us unfunded mandates, and people would say, why? This is really important. And the JLARC report came out, and it showed that we are behind the curve in funding schools in Virginia. And I think now everybody understands why it's very important. And those unfunded mandates, that's why we have the RN entering the data. Because if you have an unfunded mandate, you have to cut from somewhere. And so you cut your data entry person so that you can keep the legally required thing that you have to do. And since I'm bringing the school board perspective, we think about risk management, right? And this is actually the JLARC mentions injuries happening when the RN is not on the ground, and an inability for the nurse to prevent reduced harm increases liability. Largest districts were the ones that get sued, so it's always on our mind. Accreditation. We talk a lot about accreditation. The burden is always placed on the teacher. Why is it always placed on the teacher? Why are we not talking about school nurses and the role that health plays in chronic absenteeism, for example? One Central Virginia high school with higher chronic absenteeism rates listed anxiety as one of the top 4 reasons that we're seeing in the school clinic. The other top 3 reasons for clinic visits were headaches, stomach discomfort, fatigue, which is, if those of you who practice medicine know, can all be signs and symptoms of anxiety. Another thing, maybe having been on the school board, that you might not think of, what can a nurse do? We know that we have a problem with opiates and marijuana use in schools. I learned, because we have an RN in our schools, that there's something called cannabinoid hyperemesis syndrome that presents with nausea, vomiting, and abdominal pain. So it can look like anxiety. An RN is going to be able to tell the difference and is going to have that hard conversation with the parent. Is your kid having longer hot showers? Well, yes, they're doing that to relieve the discomfort of this problem. And Mathematic and the National Association of School Nurses teamed up to better understand the role of the school nurse in mental health, and they found that school nurses are often the first among to identify student mental health needs. I'm not surprised. I have 4 kids. All of them are, 3 of them are teenagers. One has been a teenager. She's now 21. None of them ever wanted to go to the school counselor, even when they had mental health struggles. They would always go to the school nurse because that's kind of an established, kids go to the school nurse, it starts in elementary school. Where to deploy resources, the JLARC study, which I'm a big fan of, student-based formulas are more accurate than staffing-based formulas. In Chesterfield, we actually were starting to move towards more student-allocated funding. We added extra dollars for English language learners, free and reduced lunch, special education. So what does that look like for nursing? You had the presentation. There's also the chronic absenteeism, and there's the school health data result that goes more into different health conditions. So I'm just going to put out the 3 from those reports. Diabetes, Campbell County School District, which I think is Delegate Walker's district, Campbell County, if I'm correct. Are you Campbell County? Yes. Over 1% of the kids are diagnosed with diabetes. The U.S. rate is 0.35%. I try to get some districts from everybody here. Asthma, Arlington. I think that's Senator Favola. Over 16% have been diagnosed with asthma. The U.S. rate is 6.5%, according to the CDC. I believe we have 13 districts with a really high asthma rates. Chronic absenteeism, high rates in Hampton City, Campbell County again, and Fairfax County. So we could pick, the top and deploy resources there. Also, high emergency room use. In the last session, those of us advocating for community health workers heard a lot about the burden on hospitals with overuse of ERs. Well, we could look at school districts where that is a particular problem, and you can actually use Medicaid funding to pay for community health workers, whether they're licensed or not, because we're going through the process of CHWs becoming certified, because of how you can bill Medicaid. You could also look at school districts as part of the unfunded mandate problem. We have required vaccinations, which are very important, but local health districts do not receive the resources to vaccinate our kids, which in Chesterfield, we often start the school year with 300 kids that are not in school. And this is not just a problem in Chesterfield. Most school board members actually don't even know this. I actually had a public health friend come to me and say, Catherine, do you know you have like 300 kids sitting out of school? And I said, no, this is unacceptable. Why did nobody tell me? And so then we worked on this aggressive campaign, and thankfully we have a nurse in every school. But we need to figure out that problem, and nurses, RNs should be able to provide vaccinations with parental support, of course, for the required state vaccines. Or we need to fund local health districts better if we can't make that happen. So what's next? Well, JLARC gives us numbers, right? 1 to 639 students for a nurse. Nurse supervisor is, that person can work with the public health department because they're very important. 1 to 7,024 students, although we have to maybe look at what that looks like in rural areas because they might not have 7,000 students. And pointing out that JLARC's category, I think we need to move to, that excludes unlicensed nurses. Their qualifications are similar to administrative staff. And I'm glad that you asked DMAS for some suggestions because we need the roadmap that will get us to those ratios. Funding, quickly, I fixed SOQs. You can look to JLARC for that. And I know from calling, because I was on the school board during the pandemic, I have relationships with school boards across the state, and I know from calling them that the superintendents are not, and many districts are not aware, especially in rural districts, that this is even an option. So school boards are thinking about the smaller districts, especially in rural areas, need billing support. DMAS and VDOE need to work together. Clear parental consent process for maximum participation. Other states have figured that out. Language, school boards always worry, give us this money for Medicaid we need. We're underfunded, right? We don't want this money replaced so that the county can save a couple extra dollars. So this should not shrink our budget. This should allow us to fund other needs, which look at the JLARC report. They're in there. Superintendent concerns. I hear about the SOQ changing because it's too complicated when you have folks in a category that cannot bill Medicaid and folks that can. So have a health professional category, and the JLARC actually recommended that. Demystify how the random moment in time study works, because people look at that and think, I can't do this, but Georgia and Louisiana figured it out, so can we. And survey all the superintendents, right? Because I have talked to superintendents in tiny little districts in far, far west of Virginia, and they want access to this. Why would we pass something and make it available only to the wealthier, larger districts? Address workforce issues, absolutely a problem. Chesterfield worked with the Claude Moore Foundation to help build the future nursing workforce. I would recommend reaching out to the Virginia Health Workforce Development Authority. Lauren Winston, right now they're hiring someone in the process starting in September, but they have excellent practical ideas. We're going to have to look at workforce diversity, and there's great Virginia Healthcare Workforce Data Center, but under 40, basically RNs tend to be white and LPNs black, so that is not equitable because RNs, as has been explained, have authorities that LPNs do not, and also financially earn a lot more. And school board members, we're always thinking about how to expand career paths for all of our kids. So we don't want certain kids to get tracked into certain professions. And look at the VDH Office of Health Equity Conference last year at Norfolk State. They had lots of great ideas about this. And the Eastern Virginia Area Health Education Center, AHEC, is looking into this. So ask them for their suggestions. Again, a place to start. No unfunded mandate, why we are where we are. School board members look at this and, yeah, this idea of permissive, but training, right? Training has a cost to it. So anything that has a cost, it adds up. And again, if you read the JLARC 2023 report, it puts us in a bad place. The solution, this General Assembly passed it, the governor vetoed it, is we do need some authority to raise our own revenue, or this we'll never get out of the hole. So I'm hoping, and that is 100% nonpartisan among school boards, the desire because your population gets to decide. You don't want to do it in your county, don't do it. But it is staunchly nonpartisan in school boards. So just a few things. Please support legislation that increases the school nurse workforce pipeline. So we can't say a nurse in every school until we actually have the workforce, right? It's a pathway to an RN in every school. Funding support for the LPN to RN pathway, add the UAP to LPN to RN pathway. Support local education agencies in maximizing Medicaid claiming. There's probably an app for it now, so help small districts buy that app. Parental consent, collect the data, right, so that we can show taxpayers we are wisely investing their dollars, and we need this, and it creates healthier communities. And that already mentioned that support the legislation or regulatory language that improves intra-agency collaboration. And that is all I have. That's probably a lot after 2 hours of presentation, but I just hope you walk away with there are lots of solutions out there. And I do feel bad for my mom has rural roots. And so I'm always thinking about the small little districts that it's hard to do this Medicaid thing. But maybe that's why they have some alarming health outcomes. And we have to figure out a way to make this accessible to all. That's how you find me, and it is an honor. And have a wonderful day. Unless there's any questions.
Thank you.
All right.
I have a question for Mr. Brimmer, and I should have asked it to our earlier presenters, but 82%, 108 out of 131 of our school divisions participate in the Medicaid in Schools program. But we had another number that talked about the number of schools that actually had, and that's previous presentation, that actually had full-time RNs, about 67%, 68% of our schools who reported had full-time RNs. My question is, if we have to come up with tiers for allocating money, which we usually do, we rarely get a budget allocation through that costs millions of dollars. I really would like to make sure Title I schools, each one has an RN. How can we peel back that onion so you can tell me if, because school systems they do allocate their at-risk dollars. Now, they're supposed to allocate them to their Title I schools, but they do have the authority to move money around. And I want to know if school systems have actually allocated some of their at-risk money or their own dollars to provide RNs at their Title I schools. Because I think if you look at this from a holistic approach, I mean, your Title I schools are the schools that would have a high percentage of children on free and reduced lunch. At least 40% of their population would be on free or reduced lunch. Many of the schools are located in neighborhoods Delegate Walker.
So going back to your information that you just went over, you said that there was a percentage of schools that had replied. I would like to know what schools, if you can provide that information, that didn't respond, and geographically. So were there less schools in south of West Virginia didn't reply to these surveys? Because I think that helps to give us a little bit clearer picture. While I appreciate the data that you have here, I think that would be a little bit more helpful for me, not being in the Northern Virginia area there, if that's possible. That's right. I mean, you can send out surveys and some people are going to respond, but you can't base all that information just on the responses because that doesn't give you a clearer picture of the overall need there. Thank you.
I guess we'll have to go back to our presenters for that information, but Superintendent Coons.
Yeah, we had 100% respond to the survey. We don't have everyone coming to the training and taking the Medicaid programming. So the survey covers 100% of the school divisions. Yep, absolutely.
Because it said here total schools reported, so it actually was 100%. That would have been worth noting on that. It's a good question. We did allow for public.
Yeah. But I had a question on a separate issue.
Senator Peake.
If we're still talking about nurses, there's just something before we wrap up. Are we wrapping up?
We have public comment, so I did put that on the agenda. I don't know if anybody has signed up for public comment. I will ask staff. Our rules are you should sign up before the meeting starts. And we do not take virtual public comment on these, what will I say, subcommittees or different commissions that are set up that are outside of our standing committees. So before we get to public comment, Senator Peake.
Madam Chair, and it came up earlier in one of the bills that we passed, and I voted for it. It was the bill that we mandated menstrual education. And this, let me just tell you, is the least favorite topic that I ever have to discuss is menstrual education, whatever. But I did vote for that bill. But I remember several years back, we had a bill that came forward, and it was to mandate that every school provide menstrual products in every school, that we would provide it. And I specifically remember on the floor, I asked a question. I said, I will not vote for this if this is an unfunded mandate. And on the floor, the patron of the bill promised that the schools would not have to pay for those menstrual products. That is not the case. And I remember an article, and so it's the time to bring it after looking at that bill, an article at some point in the last year about many schools can't afford it, some schools are not providing them, they don't have the funds. And my request would be, and I don't know who the appropriate person, if it's Board of Education, or whoever it is, what money are we receiving? And I think at the time the bill, then this was on the Senate floor, I was told that there would be a private entity, corporate entity, would be paying for these products. Is anyone paying for these products other than the schools? And approximately how much are the schools having to spend on these products? Just, I would like to know. And if it is an unfunded mandate on the schools, it's something I think we need to address through the budget or some other way.
Answer to that, but I will ask Mr. Brimmer.
Madam Chair, I would be happy to try to track down that data. Yeah, that bill did pass in 2020. So I'll look into the total cost and also who's bearing it, and hopefully have a better sense of that for you at the next committee meeting.
Follow-up question while you're tracking it down, just check our budgets to make sure we're aware of whether we actually made an appropriation or we did not make an appropriation. Because there may have been some money associated with it, but probably not as much as is needed.
And it seems that we may be kicking some in, but not nearly enough.
Okay. Yes, Doctor.
Yes, ma'am. Just, Madam Chair, just a quick thought, and it was brought up earlier in discussion about the shortage of healthcare providers. And clearly this conversation has been regarding nurses and school systems. Are there mechanisms to fund training that then by funding the training, you could get the appointments in the school systems? So if, and I don't know how funds flow work, but shortages, you know, if high school students and junior and two-year college and four-year college, if there could be a mechanism to get the training's funded, but then there's a return commitment that one would work in the school systems for an obligate period of time. I just didn't know in the legislative process if something like that could be considered.
We do have grants and loans that help fund medical education, including nursing training, but I am not aware of any program that specifically ties the graduate to working in the schools. Mr. Brimmer, would you enlighten us if I'm wrong?
Yeah, Madam Chair, that is a familiar structure. We do have programs like that. I'm thinking about one with teachers, a teacher program where you would have some support in the form of a scholarship, and then a requirement to work in a school division for a certain period of time after that, basically pursuant to a contract. And if you were not to meet the full obligation, then the scholarship would become basically a repayable loan. So yeah, it's a familiar concept, and certainly something we could look at for legislation for nurses or any of the pathways discussed at this meeting today.
I'm sorry. Infrequently, we will offer loan forgiveness if you go into, say, teaching or a public service. I mean, maybe we can consider a loan forgiveness kind of thing if nurses wanted to work in a public school. I mean, that might be a way. So I guess there are models for tying reimbursement and cost deferment to actual employment.
The considerations we heard through Southwest Virginia and some of the areas that may be particularly challenged that were on these heat maps. Just a thought.
Okay. Staff, do we? I would like a motion to adjourn since we have completed our agenda.
So moved.
Second, all those in favor signify by saying aye. Aye. Thank you, committee. We will.
Senate of Virginia, Richmond, Virginia.